My name is Todd Cooper. I'm from San Diego, America's finest city. I'll repeat that a few times so that you can all learn that. And it's a very good pleasure to be with you here today. I'm going to talk specifically about connecting FHIR and device information and devices. How hard can it be? And what could possibly go wrong? I'm going to give you a high-level overview of what we've done, especially over the last year and a half or 2 years, and then go into some of the why you would do that, the anticipated benefits, what the current status is, and then I'll finish up with what are we doing here at DevDays and opportunities you'll have. And there's a number of you that are experts in this area in the audience today, so I may call on you. So be thinking about questions along the way, and at the end we'll have about another 5 or 10 minutes to do questions. Okay? So are we there yet? As I said, I've been working in this area of medical device interoperability, medical device standards, informatics standards since the mid-90s. So it's been a while. Many of you I know from a long, long time back. And even though the device informatics part hasn't changed a whole lot, had many standards, there are significant challenges at actually moving that into implementation where applications developers will be able to integrate device data as easily as they do other data sources using the same infrastructure, the same APIs. So that is really our focus here, and that's what we're trying to achieve with FHIR and devices on FHIR. So today what I'll do is I'll kind of recap quickly the journey to date. Where are we? What is the group working on today? And where are we headed by the end of this year? So the destination for 2018. And what you can do here at DevDays Boston, the first version of the DevDays here in the US this week. Okay? So the journey to this point, how long has this been going on? We started actually, I don't remember the exact time we started the device informatics in FHIR discussion. I have a feeling it was in like 2013 or somewhere around there. John Rhodes, do you remember? It was in the early days. And we had some discussions. I know Chi is here somewhere. Where are you, Chi? Chi, oh, you raise your hand a little higher. Chi in the early days in San Diego, America's finest city. We did some prototyping around using FHIR technology. This would have been what, around 2013, wasn't it? 15. Okay. So in 2015, how we could use that specifically for alerting. So if a medical device has an alarm or an alert, how can you use FHIR infrastructure to communicate that? And so we did prototyping around there. A lot has happened in FHIR since then, has changed. But you know what? The device alerts and those requirements are all fairly much the same. So we did that back in 13, 14. I'm not. Okay. And then we've had a number of device-related resources, starting with the release 2. We had, in those, if you go back there, you'll see some device resources that were defined there, and they've actually evolved, and they are continuing to evolve, okay, as we understand better as a broader community how best to integrate this. So there's very specific device resources, and then there's models for how do those integrate with other FHIR resources. We created the Devices on FHIR, or DOF, in the summer of 2016. So when we first started this discussion, it was part of the HL7 Healthcare Devices Working Group, and we said, okay, well, we're part of HL7. Everything at HL7 is becoming FHIR, focused on FHIR, so we should do this. They had a lot of discussions, but we were having a hard time focusing and actually moving work products forward. So what we did in the summer of 16 was created the Devices on FHIR Working Group. If you go to the HL7 Healthcare Devices Working Group webpage and you look at the listservs, you can join that listserv. It's just a click of a button in your email. So if you want to kind of get on track of what all is going on, it's a very simple way of doing that. We actually also then very quickly had multi-organizational collaboration. I put some of those here. Obviously HL7 and FHIR as a community. Integrating the healthcare enterprise, IHE, was another group for personal health, patient care devices, the PCD domain, that has probably the most successful for point-of-care device development usage of HL7. It's version 2 based, but it gets used everywhere. So today, probably if you're integrating device source data into an EHR, it's probably coming using an HL7 version 2 feed based on this IHE profile. And then also the Personal Connected Health Alliance, or as many of you know it as Continua, the Continua Alliance, which is now part of HIMSS and the PCH Alliance, looked at personal health devices, okay? So those that might be used at home or outside of a hospital environment. And some of them are actually getting used in hospital environments now. So we said, when it comes to FHIR, we want to have a single API. We want to have a single consistent use of semantics, terminology, resources, so that whenever an application is trying to access that information, it doesn't have to figure out what device, where, how it's coming in. It can use that consistent API. So that was our objective, and we brought in many organizations to try to pull that together. We'll talk about that, and we actually resulted then, it took us 1.5 years to get to our first implementation guides, and I'll talk about why there's an S on the guides, which we did at the end of last year, so the December ballot. So we entered 2018 with those implementation guides in hand moving forward. So what exactly are we talking about when we talk about devices? I'll go through this fairly quickly because everybody has kind of a different idea of what is a device, okay? First off, here is, sadly, a typical ICU picture. This is a real-world picture. There's a real patient in this picture with all sorts of medical technology around them, many of which have some connections, but those connections are not necessarily standards-based. And when they are, they might use standards in a slightly different way. So there's all sorts of additional infrastructure that's used to connect that information from these different silos and maybe get some amount of that fed into your EHR, for example, or some other information system. We call these kind of devices point-of-care devices. They're devices that are typically around a patient in a hospital, acute care context, and they scale. Some of these are very simple, like a simple pulse oximeter from Massimo, for example. And they might be complex, like a dialysis machine or a multi-parameter physiological monitor or a ventilator. So you need to have a way of looking at this information that whether you're looking at it in the simple case or the very complex case, you don't have to have something totally different new for those. Okay, so monitors, ventilators, infusion pumps. These typically are used by professional users. So clinicians or nurses are the ones who do that. And like I said, we started the first parts of this in R2. The last version, or the current development version, release 4, has evolved new versions of this. And we're actually, as I'll talk about in a second, we're, I think, almost there with finalizing what those core resources and relationships look like. So PoCD, or point-of-care devices, are one class of device. Also, in the Continua architecture here, and this is an example of this, Melanie will go into a lot more discussion in the 220 session this afternoon on this, but these are personal health devices, and as you see, you have these devices that might be deployed in a home environment where you would have a hub that might go to a cloud-based services interface that may end up in a health information system interface, okay? And each one of those have specific design requirements and technologies to get them from here to there. Just think about the security implications alone. There's a lot to do there. So with that in mind, personal health devices, okay, home or mobile contexts are the typical uses, not the only ones of those. They're relatively simple, okay? So they typically have only a very few parameters. So you're not going to have something that scales, for example, to a ventilator, which could have a few hundred parameters, or a physiologic monitor, the same thing. So they're usually very focused, very simple. Blood pressure and temperature might be in one unit, very simple pulse ox, a weighing scale, even a urine analyzer that might have just 3 parameters that it would generate. Okay, so those are the kinds of devices we're talking about. Typically, they're used by the individual or a caregiver right there in that context. And again, we started back in R4 or R2, and we continue to evolve this, and hopefully we're converging on a consistent usage. So I'm going to talk very much about personal or point-of-care devices, those used typically in a hospital, and personal health care devices, and we'll talk about use cases actually where these are mixed and matched and where you really want a consistent API and a presentation of the semantic content to make everything easier to do. What I don't have in here are imaging devices. Okay, so imaging devices are separate. We treat them separately, and there's some other sessions here that talk specifically about how you use FHIR to access and exchange and communicate image information. For example, in lab devices similarly, we're not talking about those devices that get used in a healthcare laboratory context. Okay, we also have next generation devices. I throw this up there because Dexcom ends up being a company that does continuous glucose monitoring based in San Diego, America's finest city. And, but they're really good at that sensor technology. But what do you do with it then? So Google partnered with them to miniaturize that, to commoditize that, to make it to where you're able to take that, maybe to a Band-Aid size in that kind of a cost, and then use that to get the information to the cloud. Guess what Google is very good at? Is taking that data and crunching that. And so with these kinds of devices, and you see the wearables, you have different kinds of interfaces. These are the next generation, are actually the ones that we see being used more and more. It's what John Halamka talked about this morning, I think around his thyroid use case and how they were able, him and his wife, to use this kind of phone-centric sensor EHR cloud-based services stuff to be able to quickly get at what the issue was, get diagnosis, treatment, and get resolution in a short period of time at far less than the $20,000 it would have cost otherwise had they gone through a typical healthcare scenario. Okay, so this is the next generation. It spans context, home to hospital, that I think in San Diego, America's finest city, they're actually trialing that Band-Aid in one of the hospitals there. You go in that hospital, you get that, and they do continuous monitoring of some basic vitals right now. So they're very simple, but there's a whole bunch of them, billions and billions. Physio parameters, as well as environmental data and patient-generated data. So there's many different sources of that information that are being used. And there are all sorts of users that are using them as well. Okay, so 3 kinds of classes of data that we would like the same use of FHIR to where we can focus on the semantic content, not worry about all the mechanisms and the peculiarities of the devices. Just a couple more. I told you, consumer versus professional, scale, the volume, and the cost, they have that inverse relationship. That drives a lot of the challenges if you're a device vendor in terms of what you can support. The cost of goods to have an interface in a consumer device is far different than if you have a physiologic monitor for a hospital bedside that costs tens of thousands of dollars, if not more. Okay, so that's a key consideration. Is it regulated or not? How many of you have dealt with regulated medical devices or software applications? Yeah, there's a big difference. In fact, many companies and app developers try to find out that sweet spot of where they can get as close as they can to not being regulated, but still provide as much functionality. And it's a dangerous chicken, as in playing chicken with the FDA game, but it's done the world around. And so that makes a huge difference, okay, when you're talking about this kind of data and those systems. And is it a device or is it software? Is it software that's regulated as a medical device? That's a consideration. So when you're talking about devices, of the class of devices we're talking about, these are all things that you have to think about, okay? You'd love to just focus on, give me the data, okay? And what it takes, the simplest path to doing that. But these are other considerations that have to be borne in mind. And so with that, when we looked at FHIR, like I said, HL7 version 2 is kind of like the workhorse, okay? So we could take a standardized semantic model, so the terminology and the information model, we map that into an HL7 version 2 ORI message, okay, observation, report message, in a sequence of segments, and it was really simple. And you could get it all through there. It would be consistent data, and you could fire hose that data into any other system, and it was a very, very simplistic way of doing that. But it's exactly that. It's kind of like a point and shoot type of an interface. It's great at that. But what happens if I want to query that information? I just want this kind of information for this specific patient, or kind of an ad hoc across a given clinical area. Yeah, it doesn't really work for that. So what we saw with FHIR is that it gave us new opportunities. So devices typically represent islands of information, hundreds of parameters and point-of-care devices. Today, getting that interfacing is brittle. You get it working. It's not necessarily going to work tomorrow when anything changes within that chain. It's complex. It's expensive. It's just a real pain. That results in minimized content flows. You might have hundreds of parameters. You feel lucky to get a dozen out of those to be able to actually integrate that into your system. It was really focused on supporting flow sheets. So I want to trend this data for this patient over this time. That's really what the communications historically has been. You may have seen this. There's lots of books like this. Talks about the third wave of the internet. And Steve Case, AOL, some of you hate him because of all those stinking little CDs that showed up in your mailbox constantly. But he has an interesting perspective on this. I'd recommend it as a quick read for any of those of you that are interested. But per that, when you look at what FHIR does, it's exactly what John Halamka talked about this morning. Streaming versus on-demand access. My application wants to just get this information, and it only wants to get it when it's changed or when it's needed. FHIR does that out of the box. It wants to get this trended over the last 2 days. FHIR does that out of the box. So it's just kind of built into what you get for FHIR. So on-demand and access. Knowledge-driven. It used to be you only really wanted a few parameters because it was such a pain. Now with big data and analytics, hey, give me everything. I might not know what I'm going to do with it today, but if I have the data, I now have the services and the capabilities to crunch that and get new insight into what's actually going on with the patient, whether at home, whether in the hospital, whether mobile. Okay, so you want massive data. Guess what? FHIR handles that very well. Give me everything. Analytics, decision support, machine learning. I didn't put blockchain in here, sorry. Precision medicine. These are all things that are right there. FHIR is really that gateway that's going to help us move these new next generation applications forward. All right. I guess the last thing is the goal summarizes democratized access to granular device information. So where are we today? We're focusing in on 3 key areas. One is integrating medical device communication, MDC, terminology into FHIR terminology infrastructure. If you go to the HL7 version 2 messages, MDC is the code system that's identified so you understand what this parameter is, whether it be the text string, the reference, or the number. So we're integrating that in. We want to ensure that we have consistent use of terminology across the various technologies that are used for medical device informatics and interoperability today. I've listed a few out here. IEEE 11073 is one that's been around since the 80s, and actually the semantic part is the core that gets used. I'll talk about that in a minute. HL7, in different places within HL7, different artifacts, we use the same terminology. IHE, I mentioned that, so the device informatics uses that. The Continua, the PCHA semantic content, it uses that. So whatever we do in FHIR, we want to make sure that gets used consistently. And everybody does it exactly the same way. So we're focusing in on getting the last parts of that put together right now. Consistent tooling. So NIST has what's called a Rosetta Terminology Management, or mapping, Rosetta Terminology Mapping Management System, an online tool, RTMMS. John, is that rtmms.nist.gov? Is that where that's at now? I haven't accessed it recently. Google it. Yeah, search for it and you'll see it. But they have an online tool that has basically mapped from all sorts of the hundreds and thousands of devices a single set of terminology, 11073 terminology that you can use. And so the whole idea here is how do we integrate that tool, which many of the manufacturers are using, to the terminology services that are being used for FHIR. So we're getting that consistent tooling. And then this year, we're trying to finalize that MDC integration, like I said, extending the support for code constraints. It's not enough to know, is this parameter from this device? But you want to make sure that the units of measurement for that parameter are not all the possible ones, but the ones that are appropriate for that device, for that parameter. And it's usually one or a handful of units of measurement. Why is that important? A medical device is a regulated medical device because if something doesn't go according to plan, people can be hurt. And it can be severe, even deadly. If a ventilator fails, if an infusion pump doesn't work. And one of the key causes of that is a mismatch of the units of measurement. Drug overdoses, all the time you get that decimal point wrong, and it can have a huge life-changing impact. And so when we do the medical device terminology, we want to make sure that we're able to validate on the fly that this parameter has one of these small sets of units of measurement. If it's an enumeration, making sure it's the small set of enumerations. And so the Rosetta RTM profile that came out of IHE really looks at those code constraints. We want to make sure that what we have available today in the HL7 version 2 for sanity checking, the validity of this semantic content, we can do also when we're doing FHIR. Okay, so that's a key area we're focused on. And then value set development. So, you don't want to get the whole kitchen sink if you're just trying to do this. So being able to understand how to do the right subsets of term sets that we'd be able to support application development. So that's all the things that are going on right now. Models. So for the models, in the 11073 terminology, as I say on the bottom here, or information model, we have a simplified model that we've used across all these different technologies. It starts with a medical device system object, okay, which is it represents that top level system, okay, has a battery, has a display. It's that level of system. We then have virtual medical devices, so it has subsystems. Those subsystems may be stationary, they may be pluggable ones. If you have a physiologic monitor, for example, it may have some sensors and some subsystems that are baked into it. It may have other modules that, depending on the patient, you plug that in. If you have an Alaris medley infusion pump, guess what? You can add modules to the side. And they aren't just LVP modules. They can be a syringe pump module. They can be a PCA, a analgesia, a pain management module. And so you need to have a model that handles that kind of adaptability and variability on the fly. Okay? So virtual medical systems, then each one of those will have a bundle of information. For example, if you have a 12-lead ECG, each one of those leads generates the same information, but you want to kind of keep those separated as a different bundle of information. So we have a channel concept, and then we have metrics. Metrics are kind of metadata associated with the measurements. And then we have the actual parameters. So this is a simplified version of that, but if you have this in your mind, how we're able to scale from the overall box, the medical system, and then you get down to the actual parameters, and you understand the context of those parameters within that box, that'll make sense then as I go into how are we using FHIR. Okay? We map this directly into HL7 version 2, an ORU message, and with a sequence of segments and fields, and it's very straightforward. We're looking to do the same thing using HL7 FHIR. So when we look at the point of care devices, so those are the ones used in hospitals, what do we see? We see that we've mapped these. This is a 2017 version, by the way. So this is what, if you saw DevDays last November in Amsterdam, this is what I presented there. So we actually have a specific device component resource, you see in the middle there, and then we would profile it. Okay, so a profile of that would be a subset of the data elements and maybe some extensions supporting the MDS level, the VMD level, the channel level, and the device metric level. So if that's your abstract model, that was a very direct way of doing that. And then we had a metric. The device metric went straight across to a device metric resource. And then that went into every observation from that device then would be conformant to that device metric. Okay? So you could look at just patients and a boatload of observations. And if that's all you need, that's fine. But if you actually have, for example, the same parameter, right, from the same device or different devices simultaneously connected to the patient, you have to have a way of disambiguating that information. And so this model gives you a way of doing that, only using two device-specific resources, component and metric, and then using the device resource as a general HL7 device resource or FHIR resource. By the way, that could be a device that communicates. It could be a device which doesn't, okay? It could be like an implant, for example. A knee implant is a device. So from a healthcare context, the device resource is much broader than what we're talking about, resources that create information. Patient and then observation, okay? So that's a point of care device. The PhD, remember, personal health devices are typically much simpler, just a few parameters, so you don't need that same scalability. And so here, in 2017, what you saw was we had observations of patients, and then we had the device component, but just one profile at that system level, okay? So that's what we did last year. We actually then, as I said, at the end of 2017, we had implementation guides based on these models, and we had a lot of feedback. In January in New Orleans, there was ballot comment resolution. A lot of issues came up, and we said, well, how are we going to handle this? I'm very glad to say that also the Devices on FHIR community broadened and strengthened in terms of their dynamic engagement with each other. So before, it was a lot of device guys, right? The device folks were looking at this. Now we were able to bring in those from other areas of the FHIR community to help us expand that and understand how better to integrate that. So what we did, or what is in process right now, so this is 2018, is to get rid of that device component and just take the device, okay, and have a change in that that allows us to do these relationships. So as you see, a device metric has a relationship to the channel, VMD, and MDS profiles of the device. So the actual abstract model is the same, but what we're doing now is we're enhancing the device resource to be able to support that relationship, okay? And then probably at the top, I didn't change this for that. My assumption is that the top one would actually be the device. So you wouldn't have a separate device one there. It would be that top one. And then the observations, the metrics, those are all the same. The patient is all the same. So we've adjusted it, but not radically from a semantic content standpoint. We've just taken and gotten rid of a resource, and we've simplified it. This is the exact same thing for the personal health device. Here, we mapped the metric metadata, the numerics, into the observation, right? So all you end up having is observations, and they point to the device instance, so a single device resource. So if you're looking at personal health devices, especially from home context or mobile, it's that simple, okay? So it's a very simple model. Again, because we don't need to scale, and simple is good. So that's where that's at. I just have a few slides. These will be available, so go and look at these for the detail. But what you see is device on the left. In the middle is device component, which is going bye-bye. And on the right is, so what is the proposal for merging that in? And as you see from here, from the bullets on the side, we have some of these that are very personal health device specific, like the second one and the last one. And so the property as well as the specialization are two new data elements to the device resource that specifically help those classes of devices. And then we have other ones. So the bottom line is, the message here is it's not that ugly. It actually ends up being some fairly simple extensions of the device that allows us to simplify and get rid of that resource. I want to thank Stefan Karl from Philips who did this one. Another couple of eye tests. This is from Brian Reinhold from LNI, part of the PCH Alliance. and he's showing you some of the specific parameters. So this just helps you get an idea of the data elements in a device resource. For example, you wonder, well, what about all the firmware revisions and all of that? Well, that would be in that version data element. It would have those listed. They have a set of properties, like does it support network time protocol for time sync? What are some of the capabilities? And then each one of the VMDs would be another instance of that device resource, but they'd be profiled to have specific information for that subsystem, which, by the way, may have its own serial number, may have its own software configuration in there. And this is a similar kind of a thing, but broken out for personal health devices. That's my time, by the way. Does anybody know when we're... Oh, 5 minutes. That's good, because we're almost done. Another interesting issue that came out of the discussions at the end of the year and the beginning of this year is the differentiation between an instance of a device, you know, I have this LCD projector versus the kind. Oh, it's an LCD projector with some make and model. And how that needs to be handled differently in FHIR and the kinds of questions that you need to be able to ask and why you need to differentiate that. So, for example, when you talk about a type, this is an example that Brian Reinhold did for the PhD. You know, it's a weighing scale, okay? Go figure, it's a weighing scale. And so that's kind. That's the kind of device it is. However, there's all sorts of other information in there, and then at the end you find out what is the instance information. Well, it's this serial number, okay? And in between you have, well, who made it? And what are the kinds of information sources that it has? And what is the model and what's the version number? What are the capabilities? There's lots of discussion right now about those and where that information goes and how to capture that. So the difference between a device kind and an instance. Instance use cases, for example, what device was used for this observation? And I might have the same observation from 3 or 4 different devices connected to different body sites. That instance lets you know that, okay? Forensics, maybe the thing is out of calibration. You realize it 6 months later when something happens, an adverse event, you want to go back and figure out who was this used on? Guess what? You need that instance information for that. Or firmware revision. I have an update. I need to go out and figure out what devices do we have out there that have different configurations of information. So that's the instance one, so that I can go out and update it. The kind use cases would be like supply chain, like what do we have? So a catalog kind of a thing. What kinds of this is and that is. Or general, for example, I don't know that Joe had this serial number of an implant in his knee, but I know he had an implant, okay? So being able to have that, or being able to go back and say, who are all the patients that have knee implants? Those kinds of questions are facilitated when you have kind information separated out. Those are simplistic examples. Right now the focus is on creating a separate resource to capture that information. Okay? So for this year, and that is absolutely a picture of us trying to move that rock. There's no hill, so it's not quite Sisyphean, but it's in the right area. Again, so just to recap, PhD, PoCD implementation guides. We're trying to get the next version, a normative version for both, out, if not in the August ballot, definitely by the end of the year. And that's going to include the information I showed there. Get that MDC terminology integration finished off so that if you're writing an app, you can access that as easily as you do the others. And for here, like I said, Melanie has a presentation at 2:20, and she's going to go into a lot of detail on PhD, and so check it out. I think you'll like that one. We have a table, so if you're at lunch, we're right next to it. It's a great place to be. I paid extra for that table. We're looking at a preeclampsia during pregnancy use case, and so I have a diagram of that. Melanie is actually going to go into a lot more detail about that use case, by the way, which crosses home, clinic, and hospital with cloud-based infrastructure. So it's a great example. And then we're going to have discussions at that table specifically about events, communication, and terminology. If you have any questions, you want more detail, please come and get it. So the main takeaways, last slide for this, is that the community is actually congealed more. We're making much more progress in putting things together. The key technical foundations are falling into place. We feel very confident of that. It's been a 2-year journey, and we think we're almost there now, both for semantic content and the resources that we use. The device on FHIR informatics, though, remains a moving target. Okay, so if you're doing development today, you can do it, but know that that device is going to change the spec in the next ballot. Okay, device component is going to go away. But from a semantic standpoint, it's about the same. Okay, so beware about that. Okay, and then for developers, everybody, all of the FHIR infrastructure is identical. So it's not like if I'm doing something to get lab results and then device stuff, it's all the same infrastructure. So everything you do today for that is going to be reused. Okay, so that's a good, strong benefit. These resources here, device metric, observation, patient location, use them, because the changes to those are very minor, and they're fairly, especially observation, patient, and location, are baked. And device metric is not going to change at all. So those are very, very confident that you can use those. If you're a device vendor or developer, today you should really do want to make sure that your needs are addressed in this, okay, in the current spec. So engage today. Come and have a chat with us if you haven't already. And then an apps developer, since a lot of this stuff is identical, it's good to get experience today, realizing that things will change. We have data up on various servers that you can actually start banging about and checking out and getting a background on that. Okay? And that is it. Thank you very much, and I hope you have a great week. I'll be up here for questions if you have any.